Good evening, everyone. So I welcome you all for the Senior Registrar Forum of the month of August, which is conducted by Sri Lanka College of Internal Medicine. And this has been going on from last year with the inception of from this Dr. Ganaka Seraratna, our former immediate past president. And every month we have a Senior Registrar Forum. And this month we have selected a different topic, which is surgical, medical, and most of the patients are coming to us and we do manage jointly. And this is actually for upgrading your knowledge, mainly the senior registrars who are going to be our future internists to upgrade your knowledge. We are doing all these series. If you have any, if you think any areas you need to get improved, you need to learn, you can mention it in our forum so I can proceed with the future lectures. So without much ado, I will invite our president, Dr. Kumuduni Jayasinghe, to address the forum.
Thank you, Dr. Premali. Good evening, everyone. On behalf of the Sri Lanka College of Internal Medicine, I warmly welcome all of you, all my fellow colleagues, our senior registrars, other PGs, and all the other doctors to this SLCIM SR forum. And I would like to extend a special welcome and also would like to thank the speaker today, Dr. Ranga Wickramarachchi, who is sharing his expertise today on this very important topic, actually, which is Dr. Premali says, very useful for all of us who actually practice clinical medicine. And I would like to thank Dr. Premali, who is our honorary treasurer, who is passionately leading the SR forum. So without further ado, I invite all of you to listen to this very important lecture. Thank you very much.
Thank you, Dr. Kumuduni. May I introduce our speaker today and the topic. Today's topic is urology for internists. Our speaker is Dr. Ranga Wickramarachchi. He's a consultant urologist, senior lecturer in surgery, general surgeon, Kotalava Defense University, a good friend and a colleague. So I'm privileged to introduce him to his forum. You will realize my choice is good today after listening to his talk. Yes, Ranga, we will, I'll let you start your speech. Thank you.
Thank you, Premali, and thank you for the invitation and those kind words of introduction. Okay, it's my pleasure as always to come here and talk about this topic, and particularly in a non-neurological forum. And I hope I can do some justice to Premali's expectations, quite high, of course, I know. Of course, as Premali mentioned, a lot of urological conditions, presentations, we encounter in medical wards or medical clinic setup sometimes. And the topics I have selected to cover in a nutshell, covering hematuria, urolithiasis, it's all about stones and obstruction, and bladder outflow obstruction, and maybe towards the end, few words about urinary incontinence. I'm sure most of you all agree with what Premali said. So these topics are very familiar from the very beginning at your medical school days, your practicing doctor as an intern, and then coming to a higher level postgraduate trainee, and maybe even the practicing physicians. I'm sure these topics are well heard of, and we are quite aware about these topics and the subject area. So within a limited period, my task today is to run through some of these topics and to highlight certain special or important areas which could be quite useful in our decision making, and obviously to make our patients better. And that makes everybody's life easy, and you will find your patient is improving rapidly, and we also find that we could contribute in a timely manner. So the first area is I'll be touching upon hematuria. As you all aware, that's blood in urine. If it is quite obvious, like macroscopic hematuria, then there is no question about it. But the issue arises when it is not visible or rather microscopic. In definition, the hematuria is defined as presence of 5 or more red cells in high power field. Now the number 5, this is of course variable from country to country, the region from to a region where you are practicing. Now, for instance, if you go to Australia and if you look at the Australian guidelines, you will see this number as high as 10. Anything less than 10 for them, it's not very significant. But on the other hand, if you look at the United States, the presence of even 3 red cells in the high power field is significant for the Americans. So how severe it is? Obviously, depending on the severity of the bleeding, you will see with your naked eye what is we call visible hematuria. And if it is not identifiable with the naked eye, we call it non-visible. Actually, now if you go back to the literature in the past, you will encounter macroscopic and microscopic hematuria. But visible and non-visible are the modern terms which have replaced the old macroscopic and microscopic hematuria. This is with a reason. Now, if you take non-visible hematuria, that will cover 2 areas. One is microscopic, when you examine under the microscope. And the other one is dipstick. We know in most of the other countries, though it's not very common in Sri Lanka, the strip test has been performed to identify the red cells in urine. Not only the red cells, pus cells, nitrites, so many other components. So when this non-visible hematuria is significant, just one sample perhaps may not be significant. But if you see 3 consecutive positive samples at least 1 week apart, then this is something we need to pay attention. What we call persistent non-visible hematuria. But make sure you are not dealing with a menstruating female, probably because of contamination, and the people without any prior exercise, because immediately after exercise, anyway, you would expect some red cells to appear in urine. So what about dipstick hematuria? Of course, this is very sensitive. The problem is specificity. Now, if you go through the literature, it's in the range of 65 to 99%. There are a lot of false positives. Particularly hemoglobinuria, myoglobinuria can also interfere with this, the reaction in the strip. Therefore, ideally, now those the senior registrars who are awaiting their overseas training, and once you go there, you make sure if you see a dipstick hematuria, ideally that should be followed by microscopic hematuria in order to exclude false positives. Ideally, the same urine sample has to be dispatched for further evaluation under the microscope. So hematuria, why we bother? Is it anything significant? Yes, there are so many medical and urological causes. I'm not going to run through the list because we all know what to expect in a medical setup and a urological background. But here there are a few things I need to highlight. Urinary tract infections, pretty common, particularly in the females. If you see hematuria and the urinary tract infection, particularly the cystitis with hemorrhage, hemorrhagic cystitis is very common in our setup. And then calcular disease, Sri Lanka being a country in the stone belt, and the calcular disease is very common and will up to about 1/3 of our stone workload in our practice. And with the aging population, the BPH is also another known cause of hematuria. That is not the main concern. Our main concern, there's a set of urological malignancies. If I name according to the incidence, the highest would be bladder, followed by renal and upper tract urothelial. These will also present as hematuria, some form of a hematuria, maybe visible, maybe non-visible. If you look at the figures, patients, those who are aged more than 40 to 45 years, if you have visible hematuria, there is a chance of 14% to harbor a malignancy. If it is non-visible hematuria, up to 3% of chance that you are harboring malignancy in your urinary tract. That is why we need to pay much attention as a red flag sign, the hematuria. So if you look at the approach, now I quoted the age 40 or 45. So is it safe? Now, if you go through the previous Sri Lankan guidelines, you will see the hematuria, we have paid much attention when the patient is more than 40 years, particularly when there are risk factors such as smoking, occupational exposure to chemical carcinogens, and maybe positive family history, particularly if you think about RCC. So this approach, is it safe to our current practice? The answer is maybe not. Now we see the trend is to see a lot of young cancers. And if you ask me within last 1 year, how many young cancers I have operated, the renal cell carcinomas less than 40 years and a significant proportion. And I had a bladder cancer patient who was just 18 years. Few of patients in their late 20s. They have presented just one episode of hematuria. So therefore, we can't stick to our old guidelines in the modern day practice. You need to be more cautious about this. That's why most of the guidelines now, they don't quote about the age. Whatever the age, irrespective of the age, they complete the full assessment if you present with hematuria. Now, the common situation in our practice, what we see, I'm sure you must have experienced this. Some of our patients, they may not present until late. If we ask why, they say, I had only just one episode, and thereafter I was perfectly fine. And until you develop the next episode, maybe after 6 months or maybe after 1 year. Same way, our GPs, when they go to the GP, when you test the urine sample, probably they will assume it's a urinary tract infection and treat with some antibiotics. Unfortunately, as a coincidence, their bleeding will settle. Patient is happy, the antibiotics have worked, but they don't know they are harboring malignancy. On the other hand, stones are very common in our setup. So when you do the scan, you will see non-obstructing few small calyceal stones in their kidneys. So straight away, the hematuria is attributed to the stones. So these scenarios will give a false assurance, maybe to the patient as well as to the treating clinician. So my suggestion, always irrespective of this, you need to do the full assessment. Another thing to add to the list, patients on anticoagulants and antiplatelets. If they develop hematuria, the common scenario is we attribute that to the anticoagulants. But mind you, I had one patient recently who was following a CABG and found to have hematuria. And later on, we investigated and found patient had a bladder tumor. So though they are on anticoagulants, for them to bleed, there should be something else that is contributing. So if you think about evaluation of a hematuria patient, there are two vital components. One is imaging for the upper tract. You need to look at your kidneys, ureters, and then the renal pelvic calyceal system. Similarly, we need to evaluate their lower tract, which includes the urethra and the bladder. So obviously, cystoscopy is the choice. In addition to that, there is some place for cytology. Particularly, this is more useful when you can't find a cause with your conventional imaging and maybe endourology. But the sensitivity of cytology is very low. And particularly cytology will be positive in the presence of a high-grade urothelial cancer. So how to select the modality, the imaging modality? Our ultimate goal is to exclude upper urinary tract malignancy. So our ultrasound scan, is it safe enough? Obviously, answer is no, because small RCCs can be easily missed in ultrasound scan. And then we don't have to talk about the urothelial cancers. There's a high chance you can miss a urothelial cancer. So sometimes as the first modality, we may do an ultrasound scan, but if it is a significant hematuria, these patients need further imaging to exclude a malignancy. So how about a CT, non-contrast CT KUB? Remember, the trainees, when you request for a CT KUB, our radiologists, they will always perform a non-contrast CT KUB because that is the standard. So therefore, you need to be very specific. Again, with the non-contrast CT KUB, you can't comment anything about the soft tissue. So RCCs can be easily missed. Well, then how about contrast enhanced CT abdo-pelvis? Because you are giving contrast. Yes, it is good enough. If you are thinking about a RCC, contrast enhanced CT will give you the diagnosis and will help you for further evaluation. But don't forget that you need to tackle upper tract urothelial cancers. These cancers, particularly if they are at a very early stage, your contrast enhanced CT will also miss. Because in contrast enhanced CT abdomen pelvis, the filling of the renal pelvic ALCL system is not the optimum. Therefore, filling defects and urothelial thickening can be missed. Therefore, I would say the ideal investigation for a patient who's coming with painless hematuria, it should be CT urogram. Now, what is the place of cystoscopy? Now, suppose you have a patient who has a negative CT urogram. You are quite happy that you have ruled out a cancer. But the answer is still you are not safe to say so because your bladder cannot be assessed with your CT urogram. Now, if you look at that, some of these the tumors, the top ones, only red patches. This may indicate a CIS, carcinoma in situ, one of the nasty type of bladder cancer, which has a poor prognosis, the flat lesions. Similarly, you have the bottom, the typical polypoidal proliferating growth, which is exophytic and growing into the bladder. Of course, your radiologist will be able to detect such tumors if it is large enough even with ultrasound scan. But our worry is the flat lesions or maybe carcinoma in situ, which can be missed without your cystoscopy. Therefore, the cystoscopy is compulsory to complete the assessment. Now we will move towards stone disease, urolithiasis and the obstructed upper tract, and particularly here the infected upper tract. So I will cover two areas. One is acute ureteric colic, and the second area is infected obstructed upper tract during next few slides. Now, a typical patient coming with a loin pain or maybe loin to groin pain. Now, the first question, is it a ureteric colic? Or this could be even abdominal pain. So the clinical assessment is very important. If it is acute onset pain, acute abdominal pain, then you need to entertain other differential diagnoses. If it is a female, don't forget the ectopic pregnancies, and males or females, then diverticular disease, appendicitis, all these acute abdominal conditions you need to consider. But the problem arises when you see a patient coming with recurrent or chronic pain. There are certain other conditions which can typically mimic a ureteric colic, intermittent pain. One is musculoskeletal pain. They will say the pain is in the loin. And if it is inflammatory, if you go into the history, typically they will say their pain is fit into a typical pattern. The pain is worse in the morning. And then when they move around, mobilize, the pain is less as the day passes. It cannot happen with a stone. Similarly, if it is a mechanical type of a backache, then the pain is more towards the end of the day or maybe with loading. And pain will be less when they offload. Again, that history doesn't fit into a stone. The other problem comes with the neurological pain, maybe radiculopathy. You get the loin pain and the pain radiating across the abdomen towards the anterior part, probably mimic a ureteric colic. So you need to be very careful when you take the history. When you do the urine analysis, in 85% you will pick up hematuria if you catch the first urine sample after acute ureteric colic. Majority will be non-visible hematuria. However, remember, you can have 15% of patients having a negative urine sample despite having a ureteric stone. So the imaging, there is no argument, no debate. The gold standard is non-contrast CT KUB. In addition to identify the confirmed diagnosis that will help you to see the density and so many other advantages. But unfortunately, in our setup, that is not freely available. The access is limited in certain tertiary care centers. Even in tertiary care centers, acute setup to get an uncontrast CT could be challenging because of the high demand. So we are compelled to deal with our X-rays and ultrasound scan. Remember, if you are going ahead with X-ray KUB and conventional ultrasound scan, then you need to combine these two imaging modalities, X-ray and ultrasound. They are complementary to each other. They will definitely give a higher sensitivity and specificity to your diagnosis. The X-ray, if you do, the pickup rates, stone pickup rates are in the range of 70%. X-ray can always miss about 30% of the cases. Similarly, ultrasound scan can easily miss a ureteric stone. Therefore, negative ultrasound and negative X-ray KUB will not rule out a ureteric stone. The second question, when we try to treat these patients, are there any complications? So what are the complications that I'm going to focus? Number one, urosepsis. It's a killer. It can kill a person within few hours. Once they start the cascade, it's very difficult to turn them back. So therefore, you need to pick them early. Your clinical features, urine analysis, and inflammatory markers obviously help you to make a diagnosis. But remember, some of the patients will not show typical fever. They will straight away come with confusion and crashing blood pressure. On the other hand, you would expect to see neutrophil leukocytosis, but in severe sepsis, you can see neutropenia and maybe even thrombocytopenia. So be vigilant about two ends, either ends, when you want to make a diagnosis of urosepsis. And the second complication, the elevated serum creatinine or the acute kidney injury. In addition to these two complications, there are other factors that you need to worry. Whether it's a single kidney, single functioning kidney, whether it's bilateral ureteric stones, or maybe pregnant patient, or transplanted kidney, or maybe certain occupations where they don't have easy access to the medical advice or the treatment. So these patients, you need to pay special attention. If the answer is yes to any of these, then obviously the first two, sepsis and acute kidney injury, you need to admit them, you need to treat them as early as possible. Similarly, the other conditions, particularly the single kidney, single functioning kidney and bilateral ureteric stones, you can't manage medically. You need to intervene early. The third question we need to ask is the pain under control. Of course, you have a wide array of analgesics. It's your choice. But remember, the patient's renal functions and allergic status, particularly prescribing NSAIDs. It's very common. We see patient goes to the general practitioner where they insert a suppository and they come to the A&E, another suppository of diclofenac sodium when they come to the ward, and the third suppository, and you get a 300 milligram of diclofenac sodium within a day. We all aware the maximum safe dose is 150 milligram. So therefore, the acute kidney injury, sometimes we clinicians may contribute. So therefore, be vigilant about the NSAID, the maximum daily dose. So what is the role of medical expulsion therapy? Of course, yes, you need to be selective. As I mentioned, if the patient is free of complications, there are no special concerns, then your patient may be eligible to undergo medical expulsion therapy. But remember, tamsulosin can be given 4 to 6 weeks. The small thing I need to highlight, the maximum benefit of tamsulosin is for stones between 4 to 10 millimeter in their greatest dimension. Anything less than 4 millimeter, whether you treat with tamsulosin or not, there is a chance, good chance that they will pass it on their own, spontaneous expulsion. And if it is more than 1 centimeter, very unlikely your medical therapy will be successful. One small, special the word, please don't prescribe tamsulosin for renal stones, because the mechanism of action is tamsulosin is to relax the ureteric smooth muscles so that it will increase the caliber of the ureter, facilitating the passage of the stone. But if you think about the renal pelvis and the calyces, there's no such mechanism. There is no properly arranged smooth muscles. So the medical expulsion therapy is not valid for renal stones. Whether you give it for 2 weeks, 3 weeks, many months, years, still there won't be any benefit. In addition to that, there are few things. How about prescribing diuretics, such as furosemide? The answer is no. In fact, it could be more harmful, because when you prescribe diuretics, when the load and the workload of the kidney is increased, and then the impending or partial obstruction could be converted into total obstruction. We know the mechanism of migration, it's through peristalsis, not through flushing effect through the ureter like we expect in a normal other tube. So therefore, diuretics will not help. On the other hand, hyoscine butyl bromide, commonly known as Buscopan, has no much of effect. If you go through the evidence, that will not recommend use of hyoscine butyl bromide for acute ureteric colics. Is it important for the follow-up? Yes. Even the patient is asymptomatic, please make sure you review them maybe after 4 to 6 weeks with follow-up imaging. Quite a number of patients, they can have the stone without giving rise to any symptoms, greatest degree of obstruction. If you don't actively look for it, you can miss it. When you encounter the patient, maybe 1 to 2 years later, it will be too late. That kidney is beyond salvage. So how about obstructed infected system? In other terms, I'm talking about pyelonephritis, or may be complicated with pyonephrosis. Remember, the pyelonephritis is clinical diagnosis. These are the typical features that you would expect. We don't rely on ultrasound scan to make a diagnosis. Pyelonephritis, if it is clinically suggestive, yes, it is pyelonephritis, though your ultrasound scan is negative. So imaging, there is no place for diagnosis of pyelonephritis. So why do we insist on getting ultrasound scan or whatever the imaging done? That is for a different purpose. In a patient with pyelonephritis, it is very important to detect any ongoing obstruction. If it is a late presentation, maybe you are looking at complications such as renal abscess, perinephric abscess, or extreme cases, paranephric abscesses. And your imaging will be able to tell you when there's echogenic material within the renal pelvis indicative of pyonephrosis. That is why we do ultrasound scan, but not to make a diagnosis of pyelonephritis. And remember, if you have a patient with upper tract fullness, definitely they will need an uncontrast CT KUB to confirm the diagnosis of a calculus. Now, a common clinical scenario is you will see a patient with a dilated upper tract. As quite correctly, when you do the CT is negative. So the common interpretation is recent passage of a calculus. Is it safe? The answer is no. Particularly if you are dealing with a patient, a poorly controlled diabetic, it is not uncommon to see sloughed necrosed renal papilla coming down and obstructing the ureter. So these papilla, they are not visible in the non-contrast CT KUB. All you could see is a dilatation up to a certain level of the ureter, and beyond which could be normal. Similarly, if it is a stricture in the ureter, that can be missed in an uncontrast CT KUB. So if your patient is continuing to have sepsis, and if the upper tract is dilated, even without a calculus in the non-contrast CT KUB, may be a good idea that you need to intervene rather than waiting. So it's very important, you need to detect the obstruction early and to offer early decompression for these patients. The time is life-saving. Even without obstruction, if you have a patient with emphysematous pyelonephritis, that is a condition where pyelonephritis with gas-forming organisms, it's a type of necrotizing fasciitis that occurs within the renal parenchyma. And this is a situation where we used to do emergency nephrectomy, life-saving nephrectomy. Other than the trauma, that is the other indication for the emergency nephrectomy. but the nephrectomy rates have markedly come down, and we had good results because we used to decompress these patients even without obstruction. Moment you see gas in the renal parenchyma or the renal calyces, please make sure you decompress the upper tract. So that will definitely improve the outcome and the survival of the patient. We know the ongoing debate about what is the best mode of decompression, whether it's a nephrostomy, percutaneous nephrostomy, as opposed to a stenting. I have no much of a choice. Obviously, it's the available resources and the local expertise. If you have a good interventional radiologist who's attending on time, then obviously unstable patient, your PCN may be better. But if you don't have the facility for that, and then best to get a ureteric stent placed, and that will be a life-saving. Now we are moving towards the third part, that is to deal about lower urinary tract symptoms. In simple terms, we call it LUTS, and the relationship with the bladder outflow obstruction, BOO. So why do people get LUTS? Yes, commonly it's bladder outflow tract obstruction. Not only bladder outflow tract obstruction, there are two other causes. One is dysfunctional lower urinary tract. If your bladder is not functioning properly, or maybe the urethra, the sphincter mechanism is not functioning properly, if there's a poor coordination between the bladder and the lower urinary tract, again, patients can develop lower urinary tract symptoms. Similarly, for some reason, if you produce more urine, maybe a diabetes insipidus, poorly controlled diabetics. I'm sure the boys, you may remember when you have a binge of alcohol, and then that night will be a sort of a miserable night. You may be getting up in the night to pass urine more frequently than usual. So these all things can contribute. Not necessarily it's the bladder outflow obstruction. Now, this is one of my favorite diagrams, the right hand, the Venn diagram, where the correlation between the bladder outflow obstruction, prostatic obstruction, particularly the benign, and the low urinary tract symptoms. If you look at these three, the center, the red colored area denotes the bladder outflow obstruction due to benign prostatic enlargement presenting with lower urinary tract symptoms. What does it mean? That means there are so many other causes other than benign prostatic obstruction which could give rise to low urinary tract symptoms. Now, particularly if you encounter a patient, young male, maybe in their 40s, then don't attribute their LUTS to benign prostatic obstruction and start treating with tamsulosin. Maybe you are dealing with something else, maybe a stricture in the urethra. Because we know benign prostatic hyperplasia, it's a mechanism which starts within the prostate in early 40s, but will become symptomatic and obstruct in their late 50s or 60s. Usually, benign prostatic obstruction, what we call BPO, is less common below 55 years. So therefore, young patients, always think about something else. It is by exclusion that you need to attribute it to the prostate. The other thing, it's always important to examine. Don't forget the basics. It's very important. There are a number of instances I have seen, patients having severe degree of meatal stenosis, getting loads and loads of tamsulosin to treat their prostates. Similarly, severe phimosis, maybe with a pinhole opening, again, getting large doses of the treatment for the prostate, but their cause is something else. So is it necessary to do a digital rectal examination in the era where we rely on investigations, particularly we know the PSA? The answer is yes. The PSA alone will not help you to exclude a prostate cancer, which can always present with low urinary tract symptoms. If I quote the figures, 10 to 15% of prostate cancers, clinically significant prostate cancers, can have normal PSA. Simply because these cells are poorly differentiated, and these are cancers which are highly aggressive. So if you go by the PSA level, you are missing a significant proportion of highly aggressive, the cancer patients, prostate cancer patients, who can easily end up with a poor outcome. Therefore, you need to, not only the digital rectal examination, not only the PSA level, but you need to think about your imaging. We talk about MRI for the prostate, multiparametric MRI, prostate and pelvis, preferably with a Tesla 3 machine, plus histological evaluation with a biopsy. Like triple assessment for the breast, here we talk about 4 types of assessments: clinical, that is DRE, your biochemical PSA, imaging, ideally the MRI, and the histology, which is the biopsy. So what is the role of PSA as a tumor marker? I would always say it's a double-edged sword. You need to be very careful when you handle it. We know organ-specific, but unfortunately not disease-specific. This is not an ideal tumor marker, though we use it to diagnose a prostate cancer and to follow it up. Now the question is, what is the upper limit? Is it 3.5 or 4 nanograms per milliliter as indicated by most of the lab reports or the reference range? Now remember, the PSA value in the blood is proportional to the size of the prostate. The more the volume, the larger the PSA, higher the figure, the PSA figure. Similarly, when the age advances, the PSA level will slowly go up. So that is why we talk about age-specific PSA values. Here you could see certain thresholds for a person between 40 and 49, 2.5, as opposed to 6.5 as the quoted figure for a patient in their 70s. These are the cutoff values. So PSA of 6 could be normal for a patient in their 70s, and you don't need to really panic about a PSA value. Similarly, when the prostate size increases, the PSA will go up. That's why we need to consider PSA density. If the density is over 0.1 or 0.15 nanograms per milliliter per cubic centimeter of prostate, then that will increase the prediction of underlying cancer. So make sure that you pay attention towards patient's age and also the prostate size when you try to interpret the PSA value, not that you go by the level given by the laboratory. Similarly, not only the prostate cancer, we all know that is influenced by so many other factors. Mind you, the PSA is very expensive. In the current context, if you get a PSA level from a laboratory outside, which will cost about 9,000 to 10,000, which could be a high value for a low-income person or even a mid-income person. So therefore, if you do a PSA level in a patient who's having acute urinary tract infection, that value is useless and as if you have not done any good. In fact, you are doing more harm by doing a PSA level unless you have a strong suspicion of a prostate cancer with a hard nodular prostate in your digital rectal examination. I would always say, if there is no other indication of a prostate cancer, and in a patient with UTI, maybe a prostatitis, following recent acute urinary retention, always delay your PSA level by 4 to 6 weeks. That delay is not going to cost patients the life, because we know the prostate cancer is a slow-growing prostate cancer, unlike any other cancers. Therefore, 4 to 6 weeks delay will not make any harm. Because if you do a PSA with the prostatitis or the UTI, and if you encounter high figure, and if everything else is towards a benign disease, what I would, as a urologist, simply repeat the PSA level in 4 to 6 weeks and try to interpret. Remember, if we go by a single PSA value and try to investigate, that is, the next step would be a MRI, maybe followed by a biopsy, and the biopsy itself will carry a significant complications. Therefore, over-investigation, over-treatment will bear a significant complications, and also the financially is not cost-effective. And the other thing, when you are performing a PSA level, you need to counsel the patient. For the sake of doing, we don't do PSA, particularly if you are dealing with a patient in their 80s, usually beyond 70, 75. Now, Sri Lankan life expectancy, usually the average male, it is 76. or 77. Therefore, in my practice, usually I don't routinely do PSA level for those who are above 75 or 80. Because even if you pick up a slightly high PSA level, by investigating further, you are not going to achieve much, because the patient will end their life with a natural cause, maybe something else than the PSA, than the prostate cancer. That is the difference between clinically significant and clinically insignificant prostate cancer. The significant one you need to pick up, but the insignificant one you can always ignore. And we all know what to do when we encounter a patient to evaluate further. But the important thing, when you're asking for the ultrasound scan, always make sure, ask for the prostate size. That is P, within brackets P, that I always write. And please ask for the pre and post void residual volume. Not only that, need to ask for the intravesical prostatic protrusion, IPP, the significance of which I will describe in my next slide. So now we have a tendency, whenever you interpret ultrasound scan, you will see it's a normal size prostate. Then you tend to think, why this patient is having LUTS? Could it be something else? On the other hand, you may encounter a patient with a large prostate with no symptoms whatsoever. So do we really take this size into consideration? My simple answer, my simple explanation to my patients is no. Now, are we worried about the size of the organ if you consider any other organ in the body? Answer is no. So then why we all expect or every man to have a fixed size prostate? It's a bit of a funny scenario you think about, and you will realize how stupid if you try to think everybody should have the same size of prostate. So big variation we see, some people having 10, some people have 150, 200 gram prostate. So we never go by the size of the prostate, more than the size as indicated by many studies. What is important is intravesical prostatic protrusion, which has a direct relationship with the degree of symptoms, their quality of life, and the degree of outflow tract obstruction. Now, a few words about retention. We have three types: chronic, acute. At higher level, we talk about acute and chronic. When are we going to catheterize a patient? Is it inpatient or outpatient? To answer that question, we need to answer, is it high pressure chronic retention? In other terms, how do you diagnose a high pressure chronic retention? This is the hallmark: painless tense palpable bladder, elevated creatinine, elevated BP, and secondary nocturnal enuresis. If you further do ultrasound scan, you will see bilateral hydronephrosis and hydrourea. But remember, most of the other factors will be negative unless you focus on secondary nocturnal enuresis. So please make sure, it's a simple question you ask the patient before catheterizing, whether the patient is having a secondary nocturnal enuresis. If the answer is yes, you may be dealing with a patient with high pressure chronic retention. So why are we worried about catheterization? These patients following catheterization can end up with two complications. One is post-obstructive diuresis. Because of the diuresis, they can end up with extreme cases, they can end up with hypovolemia, hyponatremia. If we are not vigilant, we will catheterize, send them home. The following day, they will come with confusion and maybe hypovolemia. Similarly, they are bound to get post-decompression hematuria. That is because of the decompression of the bladder can end up with small lacerations which can bleed. Now, good olden days, there had been a practice to slow decompression, graduated decompression of the bladder, which is no longer recommended, because if you go through the charts, if you see the small drop in volume will give rise to a greater drop in the pressure. Therefore, whether you decompress gradually or just decompress everything in one go, there is no major difference. If they are going to bleed, they are going to bleed. Luckily, when they have a natural diuresis, this bleeding is not very significant. Usually, it's self-limiting. So because of these issues, they need close monitoring with their hourly urine output. If the output is more than 200, there are different fluid regimes. We usually replace half of the volume with 0.9 sodium chloride, which has to be an isoosmotic solution because of the hyponatremic risk. That is in addition to their liberal intake. And of course, they need electrolyte monitoring. All of these can be done when they are admitted as inpatients. On the other hand, I need to highlight that if the diagnosis is high pressure chronic retention, there is no place for medical therapy, no trial without catheter. They should end up with surgical treatment, or if they are not fit, maybe long-term catheter. These are some of the other indications for surgery. So when you treat benign prostatic obstruction medically, these are the agents available, tamsulosin being the first line agent, which gives rise to a symptomatic relief. But if you need disease modifying, then we need to think about 5-alpha reductase inhibitors such as finasteride, dutasteride. And if the patient is having secondary overactive symptoms due to the ongoing outflow obstruction, we may need to treat them with anticholinergics. So are there any concerns when you are prescribing 5-alpha reductase inhibitors? Of course, yes. If you go through the guidelines, the benefit of 5-alpha reductase inhibitors only for the large prostates. If the prostate size is more than 40, then only your medical therapy, your 5-alpha reductase will be useful if you go along according to the European guidelines. In Asian guidelines, which could be only 30. Similarly, if you are dealing with a patient who's having a marginally elevated PSA level, and then you are not quite sure whether you are dealing with a prostate cancer, it is best to avoid prescribing 5-alpha reductase inhibitors because they interfere with the original figure of the PSA and artificially bring down the PSA. So you will find it extremely difficult to interpret the PSA in these scenarios. Similarly, when you are prescribing anticholinergics as a combined therapy to the tamsulosin, make sure your patient is not having a significant residual volume. Because anticholinergics, they will suppress the bladder, the detrusor contraction. Therefore, somebody already having a significant residual volume, if you add an anticholinergic, and they will probably go into retention and large residuals. The last part of this, the presentation, I will touch upon the incontinence, which is any involuntary loss of urine, which is very common and really irritating symptom. Though a lot of people, they suffer in silence. So to understand what causes incontinence, you need to understand what is normal. The normal is during the filling phase of the bladder should have a normal capacity, normal compliance. There should not be any abnormal detrusor contractions. And the outflow sphincter has to be kept closed. And the pelvic floor muscles should maintain a normal flow. Then it is supporting the sphincter and the bladder. When there is structural or functional abnormality of any of these three, bladder, urethral, or the pelvic floor, the patients will end up with incontinence. This may be precipitated or augmented by neurological conditions, which involves with the coordination between these three structures. So these are some of the precipitating factors for the urinary incontinence. And if you classify, the common types are stress, urgency, mixed, that is both stress incontinence and urgency urinary incontinence, could be overflow when they go into retention and they will end up with overflow incontinence. And the total or persistent incontinence when the sphincters are damaged, or maybe something functional. That is where they have a structurally and a functionally normal, the bladder and the lower urinary tract. But one good example is patient with dementia. They may not recognize their environment. They will just empty their bladder as they wish. So that is that comes under functional category. So you need a good history and examination. and work to your patient. Start with voiding an assessment for pre and post void residual volumes, flow rates, and the other end, we will be doing high-end advanced urodynamics and certain endourological evaluations. How do you manage them? The first line, non-pharmacological and non-surgical therapy, followed by pharmacological and surgical treatment. Yes, simple interventions to modify or treat the underlying comorbidity and adjust their medication, maybe timing of their furosemide or the diuretic. Treat in the constipation and lifestyle modifications such as cut down their caffeine intake, tea, coffee, fluid intake, you adjust accordingly, and cessation of smoking, they all can help. When it comes to the pharmacotherapy, anticholinergics and beta-3 adrenergic agonist, these are the new agents in the practice for the urgency urinary incontinence. And the desmopressin we use off license for those who are having bothersome incontinence at times. But make sure if you are dealing with a patient with bladder outflow obstruction, your patient's urgency urinary incontinence could be due to outflow itself. There's no point treating the incontinence alone. You need to treat the underlying bladder outflow. Similarly, make sure you avoid anticholinergics if the significant post-void residual volume is there. And these patients, they will probably need bladder outflow tract surgery. There's a special category where the neurological subgroup, they develop incontinence due to neurological causes. And here the most important thing is protecting their upper tract in addition to make them continence. So therefore, to protect the upper tracts, to reduce the bladder pressures, these patients will need clean intermittent catheterization or maybe even indwelling catheter in addition to your anticholinergics. So I think that concludes the discussion, the presentation, and I'm more than happy to answer any questions from the audience.
Thank you, Ranga, for that informative lecture. You all can write in the chat box or Q&A if you have any questions. Until they start questioning, shall I ask a question, Ranga?
Yes.
So initially, you told about this. We talk about the UFR red cells. Are there difference in male and females?
Yes, initially the old literature, yes, but now we don't make any difference. Even the males and females, we take the same figure. Earlier, the male, they used to take even 3 red cells or even 1 red cell is significant, but female used to go by the figure 5, but there is no such big difference now in the two genders.
Still you take it as significant?
Yes.
Okay. And I saw the last one before the last slide for stress urinary incontinence, the drug of choice you have written as duloxetine.
Yes.
So, like, what is your experience? Is it working?
Well, it's mixed evidence we have, and certain series they say that is not the drug alone. You need to have the pelvic flow exercises and things, but this is good for a minor degree of stress incontinence. If it is a major degree, definitely they need some the surgery to strengthen the sphincters and the pelvic flow. For the minor degree, of course, yes, it may help in addition to your other whatever the strategies.
Thank you. Seems actually it was very clear, Ranga, that maybe the reason that no one is asking questions. Actually, it's crystal clear. Thank you very much for that lecture and your time as well. And I would like to take this.
That is the take-home message, Premali.
Okay.
Out of this, yes, you can just run through.
Okay. And just I want to thank Dr. Kumuduni Jayasinghe for her leadership and mentoring about this forum, and Mr. Dishan Fernando for IT support, and Gets Pharma for sponsoring the event. Thank you very much. We will meet in next month SR Forum.